What are the recent developments on this topic?
Chronic rhinosinusitis today is really considered a frequent disease. It was much underestimated in the past. We know today that more than 10% of people in Europe are actually suffering from one or other form of chronic rhinosinusitis. And there's a lot of comorbidity, so they have asthma, for example, and we understand more or less which type of chronic rhinosinusitis actually is associated with comorbid asthma. So we start to differentiate chronic rhinosinusitis in different endotypes, as we call it, different from the clinical phenotypes, and that has severe implications in the future.
How will this affect patients in the future?
We will understand more and more that this disease is consisting of at least 5 different endotypes. And that tells us that we can say something about prognosis and that we can optimize our treatment approaches for each of these different endotypes. And we already started to do that with innovative biologics, monoclonal antibodies that are directed against different molecules, which only works for a subgroup of the patients, 1 or 2 specific endotypes.
What is the take-home message for allergists and primary care physicians?
Well, the first one is don't think about sinusitis only. Look for comorbidities. Look whether the patient also has allergic rhinitis, whether the patient has an asthma. Second, treat the patient consistently, because once they have developed chronic rhinosinusitis, they need consistent treatment and they might need surgery. For the future, that means that there might be a lot of other possibilities coming up. We have patients that had 5 or more surgeries in lifetime, and I think that is something that will stop in the future.
Where is this type of research heading in the future?
We will have more and more possibilities to specifically interfere. So if we have figured out in a certain patient that IL-5, interleukin-5 is one of the major cytokines, there will be a monoclonal antibody to anti-IL-5, to IL-5. There will be anti-IL-4 receptor alpha antagonists. There's an IgE, anti-IgE approach. And we have seen in the first double-blind placebo-controlled trials already that these medications are at least as effective as surgery or as oral steroids, but they are better tolerable. So we need to find new schemes which enlarge our armamentarium for the treatment of that disease.